Please start.
Good evening, everyone. On behalf of CMS, it gives me immense pleasure in inviting all the delegates and faculties for this webinar, which is important related to prevention of non-communicable diseases. So, I invite Dr. Shanti Gunasingh ma'am, President of Chennai Menopause Society, past President of Foxy, to welcome the audience.
Yeah. Good evening to one and all. It is indeed my pleasure on behalf of team CMS 2023 to 25 to invite you all to the webinar on prevention. That stresses mainly on prevention of non-communicable diseases and, of course, metabolic syndrome, which leads to all these things. So this program has been well curated by Dr. Jayashree Gopal, and we have a host of very senior people to talk on, to throw light on all these aspects. I have great pleasure in welcoming Dr. Jignesh Shah, who's our chief guest, who's had been very popular IMS past president, and Dr. Jayashree Gajaraj, who's our guest of honor, has been held up due to personal reasons. So we'll be really missing her. And I have great pleasure in welcoming all the eminent chairpersons, erudite speakers, and of course the ever interested delegates who really make us feel that doing webinars are really worthwhile. So welcome one and all.
We will start the session with Tamil Thai Walther. I invite Meera Raghavan ma'am for midlife prayer.
Meera, are you there? Okay. Shall I continue, Ma? Meera, is Meera there?
We pray to God.
Yeah.
We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind, and body to navigate the way and trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women, and inspire us to give this gift of hope to others.
We shall light the Kuthuvilakku and start our academic session. invite Dr. Shanti Gunasingh ma'am to introduce our esteemed and renowned chief guest, Dr. Jignesh Sir.
Yeah, I have great pleasure in introducing Dr. Jignesh Shah, senior OGC Ahmedabad, practicing since 38 years, and he president of Maninagar Medical Association 24-25, past president Indian Menopause Society 2020 to 21, vice president ISOPAP 22 to 24, APMF representative for IMS, past honorary convener, state organization of OG societies of Gujarat, and past president Ahmedabad OB-GYN Society, life member of various professional organizations, and organized number of state and national level conferences and workshops, and invited faculty in state, national, and international conference. Area of special interest being high risk pregnancy, infertility, menopause, and fetal medicine. His center is recognized by Foxy for his basic and advanced ultrasound training. We are really very happy to have you with us, sir. Dr. Jignesh Shah, please. I would request you to give the chief guest address.
Sir, you're on mute, sir.
Good afternoon, friends. Namaskar to everyone. Thank you, Madam President, for good words. Thank you, Chennai Menopause Society, President Dr. Santi Gunasinghe, Secretary Dr. Meera, and past President Dr. Jaishree. She's not seen here. Is she joining?
Yes, sir. She is. No. Her aunt has met Father Falls, so she's been to the hospital.
And
Emergency at home.
Dr. Karthika also for today's invitation and giving this honor. First of all, the theme of today's webinar is endocrinal and metabolic disorders in menopause. It's a very good theme and very important during the menopausal years. Someone was talking just before this program that these webinars are very important. I remember the days in 2020 when it was our silver jubilee year and the COVID era started. At that time, we converted this adversity of COVID into the opportunity of these webinars. And daily across India, in all the corners, we were doing almost 3 or 4 webinars per day, which the physical meetings were not possible. So it was an opportunity to create awareness about the menopause and its management across the country, where all the menopause specialists will say the same words. They will say the same contents and the management will be the same. So today's talks are regarding liver and metabolic disorder, then non-communicable diseases, heart health, and weight and fitness. We all know that estrogen is not just the reproductive organ, but it has effect on other organs like brain, bone, heart, skin, and all the tissues of the body. And after it is acting just like an umbrella, and after this umbrella is gone during the menopause transition and after the menopause, its effect is seen. So this is going to be very important discussion, and I am sure the viewers will be benefited and there will be a good take-home message. My best wishes to today's webinar. Thank you.
Thank you, sir, for your address. I would also request you to release our model. This is the 17th of a series. So menopause associated disorders awareness letter, newsletter, which really empowers the menopausal practitioners. I request you to release it.
Okay, thank you. But how I do release it? It's a
Yeah, now,
e-list.
yeah, your word itself, it has got released.
Okay, thank you. This is very good book. Yes. Know your city, column. So who has prepared it? Chennai Menopause Society?
Pardon, sir?
Who has prepared it?
Yes,
Sir, our team, Chennai Menopause Society 2023-25, our members prepare it, sir. And Meera is actively involved in this. And all these talks, we put it in there so that, and we share it in the general group also. In IMS group, we have shared our Chennai Menopause Society,
For
our
everyone.
OG groups, we share everybody.
So congratulations. It is very informative.
Thank you, sir.
And thank you.
Thank you, sir. Kartika Jayashree is not there, no?
Okay, yes, ma'am. Next, we move on to the scientific session. So the first session has 3 talks given by eminent speakers, followed by quiz based on those talks. I have immense pleasure in inviting the distinguished chairpersons, Dr. Swarnalata. She is a professor from SRM Medical College. She has 16 years of clinical and teaching experience. She is an ACT core committee member and she has presented various papers at national and international conferences. Her areas of interest is high-risk obstetrics, endoscopy, basic fertility, adolescent health, and medical education. Dr. Tendral, she is a clinical lead and senior consultant in Kaveri Hospital, Radial Road. She also has 2 decades of experience in the field of OBG and she has done fellowship in minimal access gynec surgery. Areas of interest is high-risk pregnancy, advanced gynec endoscopy, and gynec oncology. Dr. Vidyalakshmi, she is the associate. She also has presented a lot of papers and publications and trained in endoscopy and ultrasound. Over to you, chairpersons.
Yes, ma'am. Let's move on to the first scientific session. It's my pleasure to introduce Dr. Shruti Chandrasekharan, ma'am, consultant endocrinologist, Rela Hospital. She did her UG from Kilpack Medical College and was awarded as best outgoing student. And she did her internal medicine, endocrinology, diabetology, and metabolism from American Board. She was awarded best endocrine fellow award in the University of Maryland Medical Center. She has numerous publications. Her special interests are transgender endocrinology and transplant endocrinology. Her non-academic interests are lifting heavy weights, yoga, swimming, and Bharatanatyam. Over to you, ma'am. We welcome you, ma'am. Over to you, ma'am.
Thank you, Dr. Vidya. Thank you so much. Thanks, IMS in the Menopausal Society for having me here this afternoon to talk on, just share my slides. Give me a minute. So what I will be talking for the next 10 to 15 minutes is on estrogen, the liver and the metabolic syndrome, the insights that we get during menopause, and how do we apply this insight into our clinical practice is what I'm going to be talking for the next 10 to 15 minutes. And I have no conflict of interest for this talk for this afternoon. So the content of my presentation is going to be, I know I'm talking to gynecology forum here, gynecologist here. I'll give a brief overview of introduction to menopause and the hormone changes. And the next talks by Dr. Sheila and Dr. Spurti is very similar to the metabolic changes that happens around menopause. I will specifically focus on the liver's role in metabolic health. And once we know what happens at the liver level, how do we use this information clinically in my practice? So when a patient comes to me in my practice, how do I apply this to my clinical practice? So that is probably the most important part of my entire presentation. So this is going to be an outline for my presentation. So we'll move on to metabolically associated fatty liver disease, menopause, and hormone change. So initially, this was called as a non-alcoholic fatty disease, NAFLD. Now they've modified it as metabolically associated fatty liver disease because they think this is a global public health problem. I think majority of us would agree to this because when we see a number of patients presenting to us with fatty liver, now we know it's a precursor to insulin resistance and diabetes, right? So we have been very, we've taken great effort in educating the patient and the family member about the importance of fatty liver and how to prevent this progression of fatty liver in the follow-up. So this affects around 6 to 45% of general population. But if you look at the diabetic specific incidence or the data that we have, is about 70% in patients with diabetes and 90% in patients who are obese or morbidly obese. And this is the most common cause for chronic liver disease in most countries, including our center, and the leading cause for liver transplantation. It is so prevalent that sometimes when we see donor evaluation, so when we have a transplant evaluation and the donor comes to donate part of their liver, we pick up a lot of metabolically associated liver disease in donor, during the first initial screening process. So that's the amount of prevalence data that we have with NAFLD or now metabolically associated fatty liver disease. So again, to sort of stress the point that this is a global public health problem that we are facing currently. And this is the sequence. I'm not going to talk to you about the pathogenesis of what happens from fatty liver to the inflammatory changes, to hepatitis, to cirrhosis. What is more important is, even at the stages of so-called NAFLD or fatty liver, patients can progress to hepatocellular carcinoma, which is very important. A lot of patients, when we do an initial screening for CT, routine CT scan, we do pick up HCC as a first initial presentation of the MAFLD, which they were not aware so far. So you don't have to have a sequence of progressing. So it doesn't have to follow a cirrhosis. Patient with even early stages of metabolically associated fatty liver disease can present or can progress to hepatocellular carcinoma. And that is a major risk that we are trying to prevent in population. And we know the menopausal effect. Now, I'm not going to walk you through this busy slide here. We know the changes that happens at the central nervous system, the sexual dysfunction or the sexual functional changes that happens with menopause. Overall, what we tell or counsel our patients, yes, we know, we acknowledge weight gain. We know that there is a weight gain in the visceral portion, the increased visceral adiposity. And the very simple tool to measure this in clinical practice, of course, BMI can be very misleading. It not be a great tool for the management of weight or obesity. The simple tool would be to measure the waist circumference. If it's over 80 centimeter in women, it would qualify as a component of metabolic syndrome. Sometimes you can even measure the neck circumference as sometimes, just to see if that correlates, or if you have to screen for obstructive sleep apnea or other metabolic disorders that could be associated with OSA. So a simple tool that I do is a waist circumference in my practice, and that really correlates with the metabolic changes, or that would be a good starting point to communicate or start the discussion, because starting the discussion would be the most challenging thing in clinical practice. And we know what happens from pre-menopause to menopause and sort of the hormonal transition. And we will hear from the other speakers as well in terms of the metabolic changes that happens around menopause in terms of change in weight, change in adiposity, which is a major thing. There is myosteatosis, there is adipose tissue, there is fat accumulation in the muscle. And that is where we talk about strength training exercise, lifting weights to preserve the muscle mass. Dyslipidemia will earn more from Spurti, and we'll talk about the metabolic disorders from Dr. Sheila. So all these things could be the changes that happens across or increase the risk of cardiometabolic risk. And where is liver in here? That is what I'm going to be talking for the next few minutes. And if you look at the menopause, the adipocyte dysfunction is thought to be a major component leading to metabolic dysfunction that we are talking. It could be hormonal changes, the aging, or the lifestyle. All these things lead to adipocyte dysfunction that leads to a cascade of metabolic dysfunction that leads to what we are talking about in terms of metabolically associated fatty liver disease. If you look at specifically the liver here in regulation of tissue health by estrogen, estrogen is just not important for sexual function. You see, it plays a very, very important role in insulin sensitivity and lipid metabolism. So the lack of which around menopause or perimenopause puts a woman or increases the risk for insulin resistance, metabolic syndrome, fatty liver, and all the other cascade of events that happens with insulin resistance. So we'll move on to the second part of my discussion. What is the liver's role in metabolic health? Why are we even talking about this today? As I told you, this is a global health problem, right? So if we talk about the liver, we know major metabolism happens in the liver, the glucose metabolism, the lipid metabolism, it's a storage. So all the metabolism and detoxification happens at the liver, and also is very crucial for hormone metabolism. And it's very important to role that hepatocytes in general, or the liver, is very sensitive to estrogen. So what happens around menopause could trigger to changes in the liver hepatocytes and fibrosis and inflammation, leading to the progression of fatty liver disease in a much alarming way. So the liver function is also very important to understand the hepatic sensitivity to estrogen. And this is a schematic cartoon of what happens at the liver. So I'm going to walk you through this. One, with aging and menopause, we have this increased lipolysis and increase in the inflammatory markers. And as I told you, this is basically an adipocyte dysfunction. The adipocyte dysfunction is the key thing that happens around menopause, aging, sarcopenia, sarcopenic obesity. We can talk about all these things. And this results in increased insulin resistance, an increase in free fatty acid. What happens subsequently, if you see, this alone is enough for the lipid accumulation in the liver. So it increases the lipotoxicity in the liver, causes advanced fibrosis. It is very important to understand patients with liver disease do not die from progression of liver disease. They would be waiting for a liver transplant, but that they would die because of a cardiovascular disease. The number one cause for death in patients with metabolically associated liver disease is not the advancement in liver disease or hepatocellular carcinoma, but it's usually a cardiovascular disease. So it's very important we aggressively control the risk factors, which is very important. And overall, it increases the mortality. If you look through this progresses on the other side, and you see myosteatosis. There is deposition of fat. Now we know fatty liver, fatty pancreas. We have seen fat around the heart, epicardial fat has become very common with the imaging modalities that we do. Similarly, you also have myosteatosis. This further reduces the insulin resistance that happens at the level of reduces the insulin sensitivity, and increases the insulin resistance at the level of the muscle. And now you have diabetes, hypertriglyceridemia, increase in pro-inflammatory markers. And that again affects the liver in terms of increased lipotoxicity. So this is what overall happens in terms of the schematic representation of what happens at the cellular level of why we are talking about the fatty liver disease today. And to sum it up, it's visceral adiposity, which is very simply you can do with the waist circumference, myosteatosis, and liver steatosis. So put together all these things, the crux of this is insulin resistance. But the question is it just insulin resistance? Insulin resistance has been implicated with PCOS, diabetes, GDM, now with fatty liver, cardiovascular disease. Is it just insulin resistance that happens at the liver of the muscle? If you look at the hepatic stellate cells, it expresses the estrogen receptors, and the estradiol inhibits the transcription factors and exhibits anti-fibrotic effects. So if a woman goes through menopause and there is an estrogen decline, the inflammatory process gets accelerated. And I will tell you the clinical implication of this. How do I apply this from bench to bedside is what we are trying to see. And this is what the studies, the preclinical studies have shown, that overall it reduces the inflammatory changes in the liver and prevents the progression of the liver disease. So these are the preclinical studies looking at the mice model, the rat models of what happens with NAFLD and estrogen deficiency. To sum this very important slide, just to have an important take-home message, estrogen deficiency promotes steatosis. That's an important thing, and it progresses. It makes the women progress to advanced liver disease. So that is from the preclinical studies. But if you look at the arrow mark that I put there, I think that is one clinically important, relevant point that we are talking today. Even in women who have the susceptibility or genetic susceptibility to MAFLD or estrogen deficiency, early menopause, here again, if you put them on resistance training and restricted diet with a high fiber diet, reduce the carbs, prioritize the protein and healthy fat, you see the reduction in the progression. Again, these are all like rat and mouse models. Even in the preclinical studies, the resistance training and diet certainly helps. I will talk about this from the clinical point of view in the next few slides as well, just to sort of show the preclinical studies showing the importance of estrogen in patients with liver disease. So to put it all in a nutshell, you have menopause here, what happens around menopause, aging, and we know increased visceral adiposity and increased insulin resistance. And that sort of makes the healthy liver progress to fatty liver. And the question that we are trying to answer here is, how are we going to prevent this? I'm a clinician. I know this is going to happen. And we see a proportion of patients presenting with MAFLD or metabolically risk. What am I going to do around menopause? What would be the clinical practice that I would use in my practice to prevent this from happening is what we are trying to answer. And overall, as I told you, it is a cardiovascular disease that actually is a major problem in patients with menopause, and even in patients with liver disease. The risk for metabolic syndrome contributes to CVD after menopause, and this is what is shown in the schematic representation here to show the end result of all these, either fatty liver or the early menopause or postmenopausal women. We are trying to prevent a cardiovascular disease. So moving on to the last bit of my presentation, how do I use this information clinically in my practice? So about 5 more minutes to finish my presentation. So I have summed it up as 10 important take-home message, from the literature I reviewed for my presentation. How can I use this in my clinical presentation? So the time of menarche and menopause is important. So now we see early menarche and early menopause. That increases the risk of MAFLD. A simple history would tell us, right? What age of menarche and age of menopause. And when we do a metabolically risk screening, how do I apply this to my fatty liver patients? It increases overall. There are enough studies, and as I told you, preclinical studies to show that it increases the risk of MAFLD. When you have 2 patients sitting in front of you in your clinic, one is a premenopausal woman and a postmenopausal woman with, say, a same set of liver fibrosis. Say you do a fibroscan, and the fibroscan shows a mild to moderate fatty liver or hepatic steatosis. The progression of this fatty liver in a postmenopausal woman is much higher than the premenopausal women. So there again, we need to spend extra time, talk to her about resistance training exercise, her diet, her sleep pattern, getting all the metabolic risk under control, because here is a woman who is definitely going to progress and probably also a very high risk of hepatocellular carcinoma, which is preventable, right? So there again, we need to focus and probably have a very close follow-up, or if required, you send the patient to a hepatologist or a gastroenterologist who can monitor the patient regularly for the progression of liver disease. And if you have a high testosterone and low SHBG, this has been shown in studies. Again, I'm not showing you all these studies in the interest of time. So if you have a PCOS phenotype, and I'm sure a lot of us during a routine PCOS workup or when you get an ultrasound to look at the endometrial lining, you see patients presenting with grade 1, grade 2 fatty liver. Again, ultrasound is not the standard of care for fatty liver evaluation. We do get fibroscan and calculate the fibroscan scoring as the different stages for fatty liver. But nevertheless, we do have ultrasound showing us the liver size and the steatotic changes when we do screen them for PCOS, right? Those are the phenotype of patients, again, who can progress faster. Already, we know PCOS is insulin resistance. A lot of metabolic disorders happen there. And that, again, with this high testosterone and low SHBG with the PCOS phenotype, they progress faster. So it's a good window of opportunity for us to actually catch them early, treat them aggressively to prevent the progression of fatty liver, or also even cause regression of fatty liver. In patients with iatrogenic menopause, like for example, if you have a surgical oophorectomy patient where you cannot give estrogen, maybe she has an estrogen responding malignancy, right? Where you can't give her an estrogen, or patient is on tamoxifen after a breast cancer surgery. Those are the patients who can really progress faster because it's one acute reduction in estrogen, right? Because of the iatrogenic menopause, and we're not able to supplement them with estrogen therapy, HRT. And again, patients who are on tamoxifen shows about 60 to 70% worsening of MAFLD. So those are the patients where I would be very close, very keen on metabolic follow-up, blood pressure, vitals, Y circumference, periodic measurements of LFTs, and fibroscan as and when required by the clinical judgment. If you have a patient with an early menopause, say a premature ovarian failure, or a patient with central hypogonadism, please use HRT unless it's contraindicated. Because recently, I usually attend a city physician meet. It's for all the physicians in Chennai. We present patient clinical scenario. The last clinical case that was presented in the city physician meet was a 40-year-old woman who has a central hypogonadism. So she has a pituitary congenital abnormality in the pituitary gland. She has panhypopituitarism. She has thyroid, cortisol deficiency. She also has she has never gone through her periods, primary amenorrhea. And she was not given estrogen, or she was not compliant in taking the estrogen. And she presented with very advanced liver fibrosis requiring for a liver transplantation surgery. So now she's considered for a liver transplant evaluation at Stanley Medical College. So in patients who would require estrogen, if it could be a central cause or hypogonadotropic hypogonadism or POF, please put them on hormones or refer them to the consultant doctor who could recommend them to be on HRT. And the importance of taking the HRT has to be very, very, very meticulously informed to the patient and the family, because the risk of that is just not metabolic disorders or insulin resistance that we are talking about, but also progression of fatty liver and fibrosis. And this young lady at Stanley who is now waiting for a liver transplant surgery. So this can be prevented. And that is exactly what we discussed in the Chennai City Physicians Meet as well last year. And what really works is what really works in your practice. A good diet, a proper sleep schedule, sticking to your chronobiology and chrononutrition is very important. Weight training exercise, building muscle is very important. It's like a mutual fund. You cannot deny, or we cannot talk to them about not having good muscle or building the muscle, because that is the only way to improve the insulin resistance and reduce the inflammatory path cascade that happens, preventing the progression of the fatty liver. So diet, sleep, stress management, strength training exercise is non-negotiable. Add on to this, you can try black coffee, 2 to 3 cups of black coffee. Some literature is there for black coffee without sugar, without milk, no sugar, artificially sweetened drinks as well. So black coffee, some data is there, but there is pretty much no role for vitamin E or other medications that are commonly used in MAFLD. So, and treating the underlying condition is very important, whether it's hypertension, diabetes, obesity, etc. HRT has been shown to be beneficial in small studies. Again, there are no long trials looking at HRT for MAFLD. These are small case control trials which showed the reduction of fibrosis in patients who have liver disease. But again, it's not approved. We do HRT for approved conditions for HRT, not per se for the liver. But again, in patients who are, requiring HRT for POF or hypogonadism, please, encourage them to use and follow up and use HRT as recommended. Not approved for all postmenopausal women with MAFLD. Lifestyle and treating the underlying cause is the major thing that we need to do from the physician perspective. And there is 1 or 2 studies which showed progesterone shown to worsen the liver fibrosis. So it is prudent to follow. It is if patients are on progesterone with advanced fibrosis, it's always good to discuss with the hepatologist and then consider putting them on that, or maybe modifying the dose accordingly to prevent this. And isoflavones and phytoestrogens have been studied along with lifestyle. But at this point of time, we have limited recommendations to use. I would probably hear from the gynecologist here who would be routinely using it. I don't have much experience with that. But again, it's been studied along with diet and exercise. Most of the studies that looked into isoflavones or phytoestrogens is along with the lifestyle. It includes strength training exercise, muscle building activity, protein intake, preventing sarcopenia. So along with the healthy lifestyle, it has shown to have some positive data there. And again, limited recommendations to use as a routine therapy. So these are the important 10 take-home message that you could use in your practice in terms of addressing the metabolically associated fatty liver disease, preventing the progression of MAFLD, and what is the use of HRT, and using them for the appropriate patients and following them accordingly. Thank you very much.
Thank you, ma'am. It's an informative and engaging session. It's a complex topic for us gynecologists, and you made it very clear and easy to understand. Thank you, ma'am, for sharing the knowledge with us. Now I invite Dr. Swarnalata, ma'am, to introduce the next speaker.
Good evening, all. I thank organizing team for giving me this opportunity. And it's my pleasure to introduce the next speaker, Dr. Sheila ma'am, for the second session on non-communicable disease and menopause, a critical window for promoting preventive healthcare. Madam is now consultant Sitapati Hospital, Chennai, founder in Training for Life, Improved Health Span and Prevention of Non-Communicable Disease, founder and past president of Indian Society of Lifestyle Medicine, and board member of maintenance of certification for International Board of Lifestyle Medicine, and chair of International Development World Lifestyle Medicine Organization, and board member of Asian Lifestyle Medicine Council, advisory board member of World Positive Health Institute, and editorial board of Lifestyle Medicine and Journal of British Society of Lifestyle Medicine. And madam has written books on lifestyle medicine also, like Get Set, Size Wise, Gain to Lose, and Fit After 40. And madam is a theatric speaker also. We are honored to have you, madam, for this important talk. I look forward to listen to your talk, ma'am. Welcome. Over to you.
Thank you so much, and thank you, Chennai Menopause Society and Jayashri, for inviting me to give this very important talk. Let me just share my slides. Is it visible?
No, ma'am. Not visible.
Not visible. I didn't share. Is it? Visible now?
Yes, ma'am, visible.
Okay. So today I'm just going to talk about menopause as a critical window of opportunity to deal with non-communicable diseases and to understand how lifestyle measures can be used to prevent these non-communicable diseases. Now, each woman's experience of menopause is quite unique, and several biopsychosocial changes occur during this time frame, with some perimenopausal symptoms affecting up to 80% of women and lasting almost 5 years. So besides the immediate symptoms, which are quite difficult and quite unmanageable for some women, as a result of lowered estrogens and other metabolic changes, the long-term dysfunctionality and non-communicable diseases such as heart disease, diabetes, stroke, osteoporosis, and even cognitive decline is quite prevalent. So it's vital to understand how to promote health and well-being in order to reduce the development of these chronic diseases later on in life. And we use this unique opportunity because not only do these women come to us either as obstetricians, endocrinologists, whatever specialty with medical problems, but they're also in a position where they can make these changes easier than women at a younger age group. So several studies, including this one by Ratnayake et al. In Sri Lanka, done in menopause, in and around menopause, to assess the improvement in the overall quality of life and menopause-related quality of life, following an interventional program, has shown an improvement in knowledge, in attitude towards menopause, and in the menopause-related quality of life. So it's hypothesized that it's the limited knowledge and negative attitude about menopause among these perimenopausal women that tends to create a multitude of health problems. So the intervention in this study was a health-promoting lifestyle education intervention, HPLEI, and there were 37 postmenopausal women with a control group of 35 women who were given regular advice for menopause. The health education sessions focused on postmenopausal health management with the necessary lifestyle modifications, which was provided for the intervention group. And they found that the attitude and the symptomatology also reduced for those women who had the intervention. Similarly, in this study by Lee et al., which was aimed to evaluate the efficacy of a multidisciplinary approach based on lifestyle medicine on menopausal symptoms, as well as preventing of NCDs. Now, the study was conducted in several hospitals, and the clinically controlled trial had an intervention group of 100 and a control group of 87. They were matched for age at menarche, menopausal symptoms, and whatever drugs that were being used at the time of enrollment. The women in the intervention group received this multidisciplinary health education based on lifestyle medicine for 2 months, while those in the control group received the routine advice in the outpatient guidance. The menopausal symptoms, physical activity, dietary status of the participants was assessed both during before, during, and after the intervention. Now, post-intervention indicated that the menopausal syndrome of the participants was significantly improved in the intervention group. There was improvement in the weekly energy expenditure, both with physical activity and exercise, and participation in the exercise, and in the intervention group compared to the control group. So there was also an improvement in the dietary intake. So greater improvements, of course, were seen in those with HRT in both groups. So this multidisciplinary health education-based approach using lifestyle medicine is very effective in the prevention and management of non-communicable diseases. So this is another scoping review of 96 articles, including 77 walking programs ranging from 4 weeks to 3 years, with a frequency of about 1 to 3 times per week, which was analyzed for the benefits towards addressing the various symptoms and also for other biological markers of chronic disease in menopausal women. Overall, 91% of the programs showed a beneficial outcome in at least one of the menopause-related medical issues. Now, this review highlights the growing interest in and the importance of such programs as a part of the management during menopause to mitigate NCDs. So why are such programs important? While they may focus on symptoms and the present quality of life, they also inculcate education and knowledge about menopause, and behavioral change is encouraged, which is very important to prevent and manage some of the most common NCDs, because it's all about behavioral modification. A change in mindset about what to eat, how much to exercise, importance of sleep, stress management, etc., is important to not just to educate them, but also to guide them as to how to carry on. And in the SWAN study, which is a multicentric longitudinal epidemiological study evaluating physical, biological, psychological, and social changes that evolve during the perimenopausal period, it was found that women who were physically more active, whether it's housework or exercise, came into their menopausal period with greater bone density and bone strength, and therefore have higher bone reserves. Women with adequate vitamin D levels had lower fracture risk. They also found that higher levels of C-reactive protein, indicative of chronic inflammation, whether it's because of life stressors and adversity or chronic disease, had a higher risk of bone fracture and faster decline in bone density. Depressive symptoms are also more common in women in menopausal time, and it's not just debilitating for the women at that time, but it also may be an indicator of future mental health problems. So the other thing is that vasomotor symptoms, though they are common, they also offer an insight into future CVD, coronary vascular disease. So the more severe the hot flushes, especially if they persist for a long time, they may be indicative of abnormalities of the underlying vasculature, like thickening of the blood vessels or plaques, leading to an increased incidence of stroke and MI. As for cognitive health, greater declines in cognitive function during midlife can increase the risk of developing Alzheimer's and dementia. So the healthy lifestyle adherence includes 5 important behaviors of not smoking, sitting less, improving sleep, and exercise and healthy diet. Now, this significantly reduced the likelihood of CVD irrespective of the age of menopause. In this paper, over 2 lakh women over the age of 45 were recruited between 2005 and 2009 in New South Wales, Australia, and they were followed for 15 years. And these women were followed up for a primary outcome of new onset of CVD. They assessed the association of premature, which is less than 40 years, early, which is 40 to 45 years, menopause, with CVD, compared with menopause at the normal age of between 50 to 52 years. The healthy lifestyle habits were assessed using a score, and these 5 factors, that is not smoking, physical exercise, sitting less, sleeping, and diet, and it was found that the CVD risk was higher in women with premature menopause and with early menopause when compared to menopause between 50 to 52 years. Among women across all ages, a high score of adhering to these lifestyle factors versus a low score led to a 23% lower odds of CVD. Whereas in premature menopause, those with higher scores to the adherence of the healthy lifestyle led to a 52% lower odds of CVD. So this is important in indicating that just these 5 healthy lifestyle behaviors seem to improve or even prevent the progression of NCD. So the paper concluded that menopause, especially those with either premature or early menopause, is a timely opportunity to screen women for cardiovascular health and promote healthy lifestyle habits. So the main intervention in menopause can be focused in and around the 6 pillars of lifestyle medicine, which is exercise, nutrition, sleep, stress management, improvement of social connections, and avoiding addictions. Now, exercise is a critical intervention during the menopause period, and it's probably one of the best researched lifestyle modalities available to change the trajectory of our health. Endorphins, which are released at the time of exercise, is one of the most important side effects or benefits of regular exercise. Now, these are endogenous opioids or neuropeptides and are released from the hypothalamus and pituitary gland in the brain during exercise. So most studies indicate that serum concentration of these endogenous opioids, particularly beta endorphin and beta lipotrophin, increase in response to both high intensity exercise as well as moderate intensity exercise. And how do they help? They help to elevate mood. They help to reduce pain by binding to opioid receptors in the brain, very similar to pain medication. They can also act as buffers to stress by modulating our body's response to stress, acting as a built-in coping mechanism. And they help improve sleep, which is an important and helpful side effect of exercise during the menopausal period, where the women suffer from fractured sleep. So both aerobic and anaerobic activities appear to increase endorphins. And during the menopausal period, keeping our mood elevated and preventing depression, anxiety, and other mood disorders should be a priority, because as we know, how we perceive our health and symptoms is highly dependent on our mood or on our frame of mind. Menopausal symptoms can be quite debilitating. Being able to perceive these symptoms and the whole menopause transition in a less negative manner will also go a long way to manage this very difficult time. BDNF, or brain-derived neurotrophic factor, is also another factor that's released during exercise, serves as a neurotransmitter modulator, and is important for plasticity, neuroplasticity. And this is important for memory and learning. The hippocampus is the region of memory and learning. Regeneration in this area is triggered by BDNF. Continuing to exercise well into the later years keeps the mind and memory sharper and protects cognitive function and memory. So through regular exercise, BDNF also leads to lower levels of anxiety and depression. So the importance of having adequate, I'm glad Shruti mentioned this several times in her talk, but the importance of having adequate muscle mass and strength cannot be overemphasized. Starting in our early 30s and continuing into our 80s, we lose up to 15% of our lean body mass. Now, for those of us who are already sarcopenic, which is most Indians, this can be disastrous. Studies demonstrate that aging itself leads to impairment in skeletal muscle, irrespective of menopause, the aging process itself. Now, this appears to be directly associated with mortality rates in the elderly. So what's required is increasing muscle protein synthesis, both with exercise and a protein-rich diet. Muscle is now viewed as a large endocrine organ, as muscle fibers release cytokines like myokines and other peptides that exert paracrine, autocrine, and endocrine effects. Now, the myokines mediate communication between the muscle and various other organs like the brain, adipose tissue, bone, liver, gut, pancreas, skin, as well as within the muscle itself. So strength training to increase muscle mass and also increase strength prevents sarcopenia, improves mobility, and even aids in recovery from various ailments. Now, as muscle is one of the greatest metabolizers of glucose, besides organs like the brain and liver, it stands to reason that it plays a very important role in the management of our blood sugar and in the management of diabetes. So stronger muscles also improve balance and decrease the risks of falls and injury, which is very prevalent as we age. In this study by Kobayashi et al., 186, it's a small study, 186 individuals were studied, of which 40% were women and 80% were Asian. And these were all type 2 diabetics of normal weight, as many of our patients are. So when divided into 3 categories, those doing only aerobic exercise, those doing a combination of cardio and strength training, and only strength training, it was found that strength training significantly decreased HbA1c levels compared to the other two groups. Strength training also increased the appendicular lean body mass, which is a given. So they concluded that even in normal weight type 2 diabetes, strength training was superior to aerobic training alone. Increasing lean body mass relative to decreasing fat mass was an independent predictor of lowering of HbA1c. So I'm stressing so much on building muscle because most of us focus only on cardio or yoga. Ideally, this should be started early in life. However, even if it was not, menopause presents this window of opportunity for intervention given the enormous benefits of building more muscle. Several papers looking at the importance of muscle even as an organ of longevity. Ruiz et al. Carried out the study of over 8,000 individuals, following them for 18 plus years, assessing their muscle strength and cardiorespiratory fitness on healthy aging. Individuals over 60 that were classified in the lowest third centile for strength were 50% more likely to die of all-cause mortality compared to individuals in the upper third for strength. In another prospective study looking at skeletal muscle as a mortality predictor, low muscle mass was valuable in the prediction of long-term mortality, especially so in females. So it's important to stress this form of exercise for menopausal women, not just for weight management, but as a form of healthy longevity. Of course, the other aspects of fitness need to be addressed. Cardiovascular endurance training to improve or maintain VO2 max, prevent cardiovascular disease, improve mood, improve bone health, and so on, especially with exercises that involve impact. Flexibility training to improve flexibility of the muscles, tendons, and prevent stiffness and pain. Mobility training to improve range of motion of the joints and also functional movement. And balance training to prevent falls and injury. Other aspects of lifestyle, which is nutrition, is another cornerstone, focusing on a plant-centric diet where enough vegetables, fruits, some amount of whole grains, pulses, seeds, and nuts need to be advised to be consumed, avoiding refined, processed, or ultra-processed products, especially sugar, consuming enough fiber, consuming heart-healthy omega-3s, enough protein, where older women require more protein than a younger person, especially if she is intending on building muscle and strengthening. The recommendation of 0.8 grams per kg body weight seems to be inadequate and actually seems to be like the minimum requirement. At this stage, women may actually go up to 1.2 to 1.8 grams per kg body weight, which is really not a lot of protein. Most menopausal women are quite receptive to improvements in dietary patterns when they see the benefits, especially of their symptoms, because a diet higher in fiber and lower in processed, refined, sugary foods is not only better for our waistline, but is also better for our microbiome, which plays a very critical role in overall health, weight, mental health, and in the prevention of NCDs. Menopausal women are typically at a point in their lives where change is the norm. Besides their periods coming to an end and the symptoms of menopause, they may also be facing several other life challenges like perhaps looking after aging parents, children leaving home, changes in their career or even retirement, loss of a spouse, and so on. And so this sets the stage for added stress and anxiety, depression, unless managed effectively. On reviewing 12 prospective studies, it was found that mindset may shape the expectations and experience of menopausal women. This systematic review by Spector et al. Found that on evaluating various studies using non-pharmacological interventions like cognitive behavioral therapy, mindfulness-based therapy, and other stress-relieving practices, they appear to be quite effective in the improvement of symptoms of anxiety, stress-related depression, and also appear to improve overall quality of life. So as we know, unmitigated stress is a primary driver of inflammation and chronic disease. And when menopause is a stressful period to navigate as it is, so advising these stress relieving practices like mindfulness meditation, yoga, tai chi, Of course, regular exercise, as we've already said, it is acts as a buffer, elevating mood and so on. Regular exposure to the benefits of nature, which is known to be therapeutic, and wherever needed, psychotherapy or CBT with a good therapist will be hugely beneficial. Encouraging women to maintain good social connections also seems to add buffer against stress. Now, sleep is another important aspect that we need to address in menopause. The negative impacts of sleep disturbances associated with menopause affects a woman's personal as well as social relationships, work, health, and overall quality of life. The close relationship between energy metabolism and sleep may implicate that menopausal sleep disturbance is closely related to the development of both weight gain and metabolic syndrome. So poor subjective sleep quality and objectively measured sleep has been linked to markers of CVD. Longitudinal data has demonstrated that a clear link between sleep disturbance during menopause transition and deteriorating mental health has been seen, especially symptoms of depression, anger, and anxiety. Now, they may have reduced alertness, impaired cognition, and they also be resulting in tiredness, irritability, which can most certainly affect relationships, work productivity, and even the ability to complete normal day-to-day activities.
Sheila, we
Yeah.
need to, I think you're running over time more than the 20 minutes. If you can finish up.
Sure, I'm done.
We can maybe address some of these things in the discussion time.
Sure. Okay. So these are just
go ahead. Yeah.
interventions, and social connections is also an extremely important aspect, and we can also talk about that. So this menopause is a unique window of opportunity, providing us with the opportunity to talk to patients regarding the various aspects of lifestyle that can be addressed. Thank you so much.
Sorry, Sheila, we have a lot of things and we've been told to finish up today because there's another webinar after this. So
no problem. Yeah. Stop share. Yeah.
Thank you,
and
ma'am.
I just wanted to also, sorry, Karthika, I just wanted to tell the participants to, if they have any questions for the speakers in this session, to please put it in the chat box so that we can spend a few minutes if necessary. Go ahead, sorry.
Thank you, ma'am, for this wonderful insightful talk. As I said, actually, our Indian women, our median age of menopause is earlier than the Caucasian. So that itself predisposes our women to the chronic health disorders, and lifestyle modification, maintaining healthy lifestyle is very important. And you rightly pointed out the importance of this healthy lifestyle on how it impacts all other systems and organs in our body. Thank you. Thank you. Next, I would like to invite Dr. Randolph to introduce the next speaker.
Good evening, everyone. Am I visible?
Yes, ma'am.
Okay. So, first of all, thanks for the opportunity, and I take immense pleasure in introducing Dr. Spurti Arun. She's a founder and managing director of ProMed Hospital, and she also has a certificate by the American Board in Internal Medicine, and she's fellow of the American College of Physicians. And she has a diploma in lifestyle medicine from the International Board of Lifestyle Medicine. She is also Chennai Ambassador for PAN, Physicians Association for Nutrition, past reviewer for American Board of Internal Medicine. And she has commitment towards health, wellness, and nutrition, and is a leader in lifestyle and preventive medicine. And she's with us to take us into detail about how menopause alters lipid profiles and what we can do about it. Over to you, Dr. Spurti.
Very good evening to one and all. Can you hear me well?
Yeah, we can, Spurti. Thank you.
Thanks a lot to the Chennai Menopause Society and Dr. Jayashree for this wonderful opportunity. We're going to talk about menopause and lipids and how menopause alters lipids and what we can do about it. Quite a lot of my slides will have overlap with Dr. Sheila and Dr. Shruti, and I think that's how we also know that those are our real take-home points for today. Some of my slides are very busy and I know we are short on time, so we're going to be very crisp and I'm going to try and give the synopsis. I'm going to skip these introductory slides about menopause, 12 months without periods is basically menopause. And we see a lot of hormone fluctuations around that time. We also know that there is higher risk of cardiovascular disease in the perimenopause and menopausal area, especially in postmenopause. And this is because of estrogen deficiency as well as dysregulated lipid metabolism. Estrogen, especially the E2, plays a protective role in the cardiovascular system. And E2 gets produced by using low-density lipoprotein cholesterol as a substrate. So as the E2 level starts to decrease, we start seeing that the LDL-C level starts to increase. These are just basically the risk factors that we all know about: type 2 diabetes, obesity, lipid disorders, hypertension. I think this is a similar slide from a previous speaker, so I'm going to just move on. Now, what do we see during menopause and how the fat mass and fatty acid metabolism changes? We see that there's a lot of fat redistribution around perimenopause and menopause. We see that fat from the gluteal and thigh starts to decrease, and there is more accumulation of abdominal obesity and central fat around the perimenopause and mainly postmenopausal times. The decrease in estrogen concentrations, along with the hyperandrogenism that we tend to see, there's a decreased sex hormone binding globulin, which also causes increased bioavailability of testosterone. Now, with this combination, we see that postmenopausal women can almost have a 2.88-fold higher risk of abdominal obesity compared to premenopausal women. So why does this happen? First of all, visceral and subcutaneous fat cells have estrogen and androgen receptors. And so all fluctuation in hormones starts to affect it. Depletion of E2 downregulates the expression of genes that are required for efficient energy expenditure, as well as the genes that are involved in fatty acid metabolism. Visceral fat also has higher lipolysis rate, causing an increase in glycerol and free fatty acids from triglyceride, which in turn goes to the liver and starts to increase the hepatic insulin resistance. We kind of touched base on all this with Dr. Shruti's presentation. So the increased adiposity, hyperinsulinemia, insulin resistance, all this combination starts to increase the postmenopausal dyslipidemia, obesity, metabolic syndrome, and type 2 diabetes. Sarcopenia, again, a very, very important part through perimenopause and menopause. Sarcopenia is the degenerative loss of skeletal muscle. We see about 3 to 8% loss every 10 years from the start of 30 years, and this accelerates with aging, especially around menopause. Sarcopenia is extremely important, especially for the Indian ethnicity, because of its increased risk of functional disability, overall mortality, fracture risk, fall risk, and quality of life that decreases. The loss of lean body mass is associated with lower energy expenditure during rest. So basically, your basal metabolic rate starts to drop, along with increased insulin resistance. We also see a lot of different other hormones that change. Say, for example, there's an increase in leptin and resistance, resulting in leptin resistance, downregulation of ghrelin. Again, this combination starts to increase insulin resistance. Metabolic syndrome, again, something that we're all familiar with. So I will kind of skip all of that. A very, very brief introduction of the different lipid fractions. LDL is your bad cholesterol. It's a major carrier of cholesterol, almost 60%. What does LDL do? It basically transports the cholesterol to the tissues and starts to deposit in vascular endothelium as well as plasma membranes. A lot of these peripheral cells have ApoB100. So these are the fractions that sometimes we see when we are looking at cardiovascular risk. So LDL basically causes increased atherosclerotic plaques. HDL is your good cholesterol. What does it do? It does the reverse. It collects all the unesterified cholesterol from all over the cells, takes it to the liver, and gets excreted via bile. So this is your good cholesterol that's actually protective against heart attacks and decreases your atherosclerotic risk. Triglycerides, I think, are very important. In the last 10 to 15 years, a lot of evidence that has come up about how important triglycerides are. These are not just important, they are an independent cardiovascular risk factor. And most of your stored body fat is in the form of triglycerides and 95% of your dietary fat. And in order to generate energy, fatty acids are released from triglycerides, and these then get transported. And we already heard about how it connects with hepatic insulin resistance. So what really happens with menopause? We start seeing a high level of total cholesterol, high level of LDL, triglycerides, ApoB, as well as a high total cholesterol to HDL ratio. Now, a high total cholesterol to HDL ratio is a very important ratio, even when compared to just pure total cholesterol. The dysregulation of lipid metabolism, as well as the accumulation of visceral adipose tissue, is all caused by the estrogen deficiency. Another important take-home point is that it's the small and dense LDL particles that increase during menopause. And these particles are recently being found that are more important determinants of atherosclerosis and CVD. Similarly, so when you look at HDL, there is an increase in the small HDL subfraction 3 and a decrease of the large cardioprotective HDL subfraction 2. So what can we do about it? Ultimately, a lot of this pathophysiology, most of us know in our clinical practice, but how do you manage this? The first thing is your dietary recommendation, again, has been touched base by the previous two speakers. A high protein, low calorie diet can help you. So what do? You can do one of the below suggestions. You can do 1,200 to 1,500 kilocal per day. But remember that your kilocalories are really dependent upon a lot of things, including your muscle mass, height, weight, ethnicity, etc. Or you could do a 500 to 750 kilocal energy deficit. Or you choose one of your evidence-based diets that are based on avoidance of high carbohydrate foods, avoidance of low fiber foods or high fat foods. So going with whole food, plant-based kind of diets to create an energy deficit. And basically that's how you kind of achieve this. The second thing is a higher protein intake, like Dr. Sheila suggested. Even though 0.8 grams per kg is what is recommended. During sarcopenia, during muscle mass loss, during weight loss, a higher protein intake at about 1 to 1.2 grams per kg per day is likely going to help compensate and decrease the amount of muscle mass loss. There's even a cross-sectional study with 4,900 Korean women where they looked at their traditional healthy diet with sea fish, seaweeds, a lot of fresh fruits, vegetables, in comparison with fast foods and animal foods, sweets, etc., had a protective effect against dysregulated lipid metabolism. Exercise, again, lots of overlap, but I think that's the one take-home point that we all want to drive today. Strength training is extremely important to fight against sarcopenia. As women, don't be scared to lift heavy. You just have to take some precautions. Lift heavy, but make sure your posture is good. You have enough protein intake. You have enough sleep and recovery days. As long as you're doing all of that, don't be scared to lift heavy. The other important thing is that how you get into menopause. So make sure that you have a very active lifestyle, hitting at least 6,000 to 8,000 steps per day. And the more muscle mass you have when you enter into menopause, the better you are. But don't worry. I mean, even if you're starting late, it's still always good to start. Certain other supplements that are very useful. Vitamin D. Now we know that vitamin D is associated with a lot of the cardiometabolic factors, blood pressure, elevated triglycerides, HDL levels, metabolic syndrome, etc. There was a randomized control trial, very few, 76 postmenopausal women who were vitamin D deficient, and they gave vitamin D 2,000 international units once daily for 12 weeks, and actually saw that most of their lipid abnormalities started to improve and compare with the control group. So role of vitamin D supplementation, we don't have enough evidence, but I think it's a simple thing that we can start taking into our clinical practice. Omega-3 fatty acids, again, a lot of proof there. Linoleic acid and linolenic acid are your essential fatty acids. They have to be obtained from the diet. Our body can't produce it. Omega-3 fatty acids protect against obesity and metabolic syndrome. So how much is good? 900 milligrams of omega-3 per day has shown to significantly decrease BMI, waist circumference, blood pressure, serum triglycerides, as well as the inflammatory markers, interleukin-6 and insulin. An omega-6 to an omega-3 fatty acid ratio is important. In most of the developed countries or countries where we are seeing a lot of refined carbohydrates and refined processed food, we almost see a ratio of 15 to 20:1. Now, this is extremely detrimental to cardiovascular health, but a ratio of about 4:1 has already shown almost 70% decrease in mortality rate. Now, decreasing the omega-6 to omega-3 ratio even further actually has shown to decrease risk of breast cancer as well as suppresses inflammation in rheumatoid arthritis. Antioxidants, again, oxidative stress is a very important factor that plays in cardiovascular health as well as metabolic syndrome, chronic inflammation. And there are quite a few number of studies that have shown the addition of vitamin C, vitamin E. I'm going to skip a little bit of that. So what can we do? Start to increase our intake of exogenous antioxidants. So vitamins, vitamin A, beta carotene, vitamin C, vitamin E. Plant flavonoids, soy isoflavones, all of these are very commonly found in fruits, vegetables, soybean, coffee, tea extracts. Coffee and tea without the milk and sugar. Resveratrol is another important antioxidant. This actually helps with quality of life parameters in some of the studies, such as dryness of vagina, heart discomfort, sexual problems. Phytochemicals and probiotics. Okay, what are phytochemicals? These are the nutrient components of plants that contain bioactive components. Now, these basically function as antioxidants and work to protect us from oxidative stress. They can bind to gene sequences and regulate protein synthesis as well as hormone synthesis. Now, one of the largest phytochemical groups is the flavonoids that we hear about often, and this is is abundant in plant foods, whole grains, vegetables, fruits, red wine, and even dark chocolate. Again, dark chocolate, when we talk about dark chocolate, we are talking about 80% dark chocolate. Again, why is that? Because that has lesser milk and sugar and more cocoa or cacao. Probiotics, as we all know, these are microorganisms that kind of keep your gut microbiome healthy and help with preventing infections, producing vitamins, and a lot of wonderful things. A lot of research studies have shown multi-strain probiotics have actually helped to even improve vascular endothelial function by decreasing arterial stiffness. Now comes, the one question, so should I just start supplementing with everything? Shall I take some turmeric? Shall I take some, ginger supplements, etc.? Supplements can never equal what natural whole foods can provide us. Natural whole foods provide us with a more balanced way of doing this. Now, of course, there are some supplements that adding, like say, for example, vitamin D and omega-3s are something that I do add to kind of give a boost. But as long as you're getting a majority of your antioxidants, vitamins, and minerals from whole food, natural whole foods, because that's the only thing that's also going to give you your fiber. So by making sure of that, you can really improve your cardiovascular health. So I'm really done with most of my presentation. I'm just going to touch base on statins, just because this is talk on lipid metabolism. So for prevention of cardiovascular disease, you're looking at your ASCVD risk. Now, anything that's less than 5%, low risk, but the recommendations are still that we talk to them about lifestyle. So diet, exercise is something that you're going to talk about to everybody, sleep and stress control. More than 20% choose a high-intensity statin that would reduce your LDL-C by 50%. That is a class 1 recommendation. We don't do a very good job with that. Now, the intermediate risk is where you choose the moderate intensity statin. So 7.5 to 20%, you choose a moderate intensity statin to reduce your LDL by 30 to 49%. The only other point here is that even during the reproductive and hormonal, during the reproductive times, diagnoses like preeclampsia, early menopause, PCOD, infertility, all these autoimmune disorders increase your risk for cardiovascular disease. So when you have patients like that, even in the premenopausal time, start having a lower threshold to screen them for cardiovascular disease. This is, I get a lot of questions about coronary artery calcium scoring. When do I use it? Should I do it? So again, a very brief point here. Now, when you have an ASCVD risk less than 5% or more than 20%, you're very clear. No statins for the first one, yes statins for the last one. Now, the confusion occurs in the in-between groups. Now, somewhere between 5% to less than 20%, if you have doubts and you're wondering and you're not completely convinced, a coronary artery calcium score can help you. Now, in this, if the coronary artery calcium score is 0, then you really don't have to do a statin. But once the coronary artery calcium score starts to go up, you know that the risk for atherosclerosis and cardiovascular mortality is going to go up. And so the more than 7.5%, you do recommend a statin. And this graph basically tells you the same thing. See the lowest one here, that is a CAC of 0. And even after 12 years from your basal exam, it's not really hitting cardiovascular mortality. Whereas this curve right here of a coronary artery calcium score of 300 plus, even within 3 years, you start seeing a lot of cardiovascular morbidity and mortality. Hormone replacement therapy for anybody with less than 5% or less than 10% cardiovascular risk, you can consider hormone therapy replacement if it is needed for other things. But anybody with more than 10% ASCVD risk, hormone therapy should be considered high risk. Last point here, cardiovascular risk increases from premenopausal to postmenopausal women. And the most important thing is postmenopausal diabetic women, the risk is even higher. So always have a low threshold for people with certain increased risk factors, just have a low threshold to screen them. So in conclusion, cardiovascular disease is much lesser in adult women compared to men, but their protection goes off once they hit menopause. With menopause, you start seeing a more atherogenic lipid profile. Weight, obesity, central obesity starts becoming a problem. The thing we need to remember is cardiovascular risk scores underestimate the risk of women. So we as healthcare professionals need to keep this in our mind. And the other thing is that women do present with atypical angina symptoms, right? In a diabetic postmenopausal women, fatigue can sometimes just be your presenting factor for cardiovascular disease. So have a very low threshold with these groups of women. And not only that, even after coronary event, women have a higher mortality and morbidity compared to men. So have a low threshold, screen them, put them on a statin if needed. Definitely diet, lifestyle, exercise. I cannot stress more. Thank you so much.
Thank you, Dr. Spurti Arun. That was in detail about heart health and menopause. So menopause alters lipid metabolism and it increases the cardiovascular risk. And however, through diet, exercise, and lifestyle changes and medical guidance, we can take proactive steps to maintain a healthy lifestyle. You've told us in a very clear, crystal clear presentation. Thank you so much, ma'am.
Thank you.
All the participants would have got very good take-home messages from all the 3 important talks. Now it's quiz time.
Yes, ma'am. Shall I launch the first question, ma'am?
Yes.
Can you see the screen, ma'am?
Yes, it's visible.
Yeah. I request Kartika, ma'am, to read it.
So, which lifestyle behavior is not advisable for prevention of non-communicable diseases? Physical activity, diet, smoking, maintaining a healthy BMI.
I request all the delegates to participate in this quiz. Last 5 seconds. Time up. Second question.
Menopause is a window of opportunity to address prevention and lifestyle management because women tend to visit their gynecologist or primary care physician at this stage. Women are more willing to attempt behavioral change at this stage. Women tend to have more time and perspective at this point in their lives. All of the above.
Five more seconds. Time up. Third question.
An effective strategy to prevent osteoporosis, fall, and fracture post-menopause. Sleep better, swimming, strength training, meditation.
Five more seconds. Timer. Fourth question.
What role does estrogen play in liver health? It increases bile production and reduces liver inflammation. It decreases bile production and increases liver inflammation. It has no impact on bile production or liver inflammation. It only affects liver health in men.
Five more seconds. Timer. Fifth question.
What is a significant risk factor for metabolic syndrome in postmenopausal women? Increased physical activity, high estrogen levels, balanced diet, central obesity.
Five more seconds. Timer. Thank you.
So we move on to the second session, which is a panel discussion on weight of fitness, where and how we draw the line.
Just a second, ma'am. I'll display the slides.
For this, I invite Dr. D. Geeta, Associate Professor, Department of Obs and Gynae, Dindigul Medical College, past Oxy Society Secretary, and she is the recipient of A.L. Mudaliar Fellowship Award, to introduce moderator and panelists.
Thank you, Kartika. Am I audible?
Yes, ma'am.
Good evening, all. I welcome you all for our panel discussion. The topic given was weight or fitness, where and how do we draw the line? For this, I invite the moderator, Dr. Jayashree Gopal. All of us know about Madam. Madam is Vice President, Endocrine Society of Tamil Nadu and Puducherry. She did her MBBS and American Board Certified in Internal Medicine, Endocrinology and Diabetes. She is Director, Diab Endo India, Chennai. Founder, Trustee of Diab Endo India Foundation. Preserving Health Across Generations, Senior Consultant Endocrinologist, Apollo Hospital, Chennai. She is recipient of the Vocational Excellence Award from Rotary Club, awarded Dr. Sham G.P. Moses Oration at the API Chennai Chapter Annual Conference, and Madam is EC member of the API Chennai, EC member of the Chennai Menopause Society. And the panelists were, should I introduce the panelist or Dr. Meera Raghavan? Madam is Secretary, CMS. All of us know about Meera ma'am. Dr. Nirudhya. Madam is Consultant, Sitapati Hospital. Dr. Shaini Chandan. She is founder, partner, Art of Eating Nutrition Clinic, Chennai. Dr. Karpahambal Sairam. Madam is EC member of our own Oxy. Over to our moderator, Dr. Jayashree ma'am.
Thank you very much, Geeta, for that kind introduction. And before I proceed, I'm just going to draw up my presentation. Sorry, just give me a minute. I just want to thank Dr. Spurti, Dr. Sheila, and Dr. Shruti, who had to leave early because of her clinic, for being here today. And I would also like to thank all the panelists. What I'm going to be talking about today's topic, which is very, at least close to my heart, because I think all of us who deal with women who are trying to lose weight know like what a challenge it is. So I really wanted to get, I know that, for example, Meera and Nritya, they're all very much into like exercise. And of course, Shaini is our celebrity nutritionist. I learned that Karpagambal is a cyclist. I didn't know that, Karpagam. So thank you. I mean, thank you for being here. I thought I'll pick your brains about what is more important to emphasize to women. We keep saying weight. You know, where do we draw the line? Obviously, fitness is equally, if not even more important. So I just wanted to have a discussion and hopefully learn a few things also along the way. Let me just share my screen. Yeah. So The first question is for Meera. How do we define healthy weight versus fitness in clinical practice? Dr. Meera, you're there?
Yes, yes.
Yeah.
Hi, thank you once again. Good evening to all. Definitely, the BMI is kind of clouded what the healthy weight is in terms of the BMI being American standardized, it is moved further and further. However, we tend to forget or be in the oblivion of the fact that thin patients can also be less fit, or thin women can also be less fit. So, though we call it a weight as an arbitrary standard for measuring one's health, it's about how metabolically fit we are, and the metabolic parameters are more important than just an arbitrary weight, and it's more related to the weight for height. And nowadays, we've got the body roundedness index more than the BMI, and it's about the circumference around your waist, which is more important rather than the weight itself. I think, in my personal opinion, though there are universally accepted norms for these, it has to be individualized based on the person's lifestyle, the nature of the job, the life risk factors, the family risk factors, and so on and so forth. And it's highly individualized.
Thank you, Meera. Before we go, I just wanted to, this is a recent article. It was just literally published about 2 weeks back in the Lancet. This is a, like a guideline document on obesity, and they're defining clinical obesity versus preclinical obesity. And I just wanted to quickly point out that clinical obesity is people who have specific signs and symptoms of ongoing organ dysfunction due to excess body fat. And exactly what Meera was saying about metabolic health. And preclinical obesity is where it was a term that we used earlier was metabolically healthy obesity. So people who have excess body fat but have no identified ongoing health complications. So meaning their sugars are normal, lipids are normal, BP is normal, uric acid is okay. They're not having any urinary incontinence. It's very unlikely, but even then you have to aim at risk reduction. And I thought it was interesting, like what Meera said, now we've moved on from just using BMI or waist circumference. You can use that as a guide, that we have to get more and more into the habit of looking at, is this person weight affecting their body organs?
Yeah.
They may be having a BMI of 22, but be having a fatty liver. So this is important to keep in mind. And this is a list of all the things, organ dysfunction. So, for example, urinary, recurrent or chronic urinary incontinence. All of us are going to face this when we look after women in the menopause. So this is considered, so if you have a lady with this, with some amount of extra body fat, she's considered to have obesity. All of you can look up this paper. It's available. It's a free this thing, but I just wanted to put it up saying head to foot, they define all of the conditions that go along with the obesity. Now moving on to Shiny. And Shiny, I'm sorry, I keep either calling you Shiny Chandran or Shiny Surendran. I always seem to get
Chandran
it
is
wrong.
it's my maiden name. I think
Okay.
it's fine. Yeah.
Okay, sorry. Apologies to your husband.
Not an issue.
Yeah. What are the risks of focusing solely on weight reduction? You do a lot of work with sports people, so you're very familiar with this. So what is the risk of just focusing solely on weight reduction as opposed to improving overall fitness? Are there actually cases where weight loss is detrimental in spite of the fact that your fitness markers have improved?
Yeah.
What do you think about this?
Yeah, thank you for having me here, Dr. Jayashree. Besides metabolic syndrome and the MAFLD and PCOS cases, we also see the fitness competitive athletes as well as the weekend warriors, or the ones who just do their recreational sport over the weekend. And what we get to see is definitely it's a huge risk factor, because there are people who are going on crash diets where entire food groups are eliminated, be it dairy products or even lentils completely, because they have bloating and flatulence and all of that. And the repercussions are low immunity, sarcopenia, and also the body image. And after a point, like when they get back to eating the regular idli dosa, rasam sadam and all that, what really happens is a lot of fear. Mental health is completely, shattered, and they're very, very scared to even eat the basic things that they've eaten right from childhood. And the risk factors, as I said, it's not just about losing weight, it's also about addressing their body image issues, and also getting a customized plan, body composition analysis, be it a DEXA scan, or perhaps even something as simple as, in our clinic, what we do is we have a body composition assessment machine, and we invite all people to bring their family members to just come and get a BCA done, because DEXA is expensive, 3,500 for a sitting, and this is the minimal investment that we could do for a small clinic. And we keep asking people to come and check, because even you do have lean PCOS, right? So it is very, very important for people to ensure that they don't end up losing muscle mass, making sure they have strength training, and also including a lot of protein and fiber, because they have to feel quite satiated, and also include healthy fats so that it gives them the satisfaction of having eaten a meal. And the omega-3 is pretty much quite deficient. So we have to look into all these factors. But again, the focus is so much on carbohydrate, because as Indians, we include quite a lot of carbohydrates in our diet, and there are so many festivals around, and people also need to learn to navigate through all of this. So a very systematic, comprehensive assessment, including reports from the doctor who was referred, and then the fitness expert, or else the physiotherapist giving a or scorecard, or else an assessment, and then sitting with all these reports and customizing a plan based on their purchasing ability, their socioeconomic status, and also how much they travel, what's their occupation all about, and do they have the resources? Does the spouse even show up for the consultation? And how much of moral support do they have at home? And are they in jobs where they end up traveling, like, say, 26 days in a month? So all of these factors have to be taken into account before customizing a plan. So it's important to make them understand that, you can go ahead and lose 10 kgs in a month. We have done that for a lot of people, because they are in certain industries which, like, say, media. But then, since we're all professionals and we need to go about taking care of our family, and then also, we have personal commitments, and we are not like the ones in the media for whom looking important is so important for their career. Here we focus on the metabolic markers. So I think it's important to educate people about muscle mass, BCA, sarcopenia, and all of that. And it's not just about weight loss.
Yeah, thank you. I mean, really important point about the weekend warriors and the people who go on crash diets. Dr. Nritya, again, thank you for joining us. I think the previous speakers addressed all this insulin resistance, visceral fat, but really what I want you to talk about is this question that I've added at the end. Can people with a high BMI still have a good metabolic health if they are fit?
Thank
Nritya,
you.
are you here?
Yeah.
Yeah.
Thank you for having me here, Dr. Yashri. Thank you to the Chennai Menopause Society. So I think even Dr. Meera had mentioned, so the BMI is kind of, I'm not too sure it's very valuable right now in this age, because it doesn't take into account the body composition. So people can have a very high muscle mass. So you have people who are bodybuilders, who are weightlifters, who will have a high BMI probably because they are big. But they may have a good metabolic health. Their profile might be fine. So just because they have a high BMI or they are overweight according to the BMI doesn't mean that they are necessarily unfit. I think the cardiorespiratory fitness is important for everybody. So that also has to be taken into account. But yeah, I mean, people with high BMI can still maintain good metabolic health, but it is about body composition. So as Dr. Shaini pointed out, body composition is important. So you need to have more muscle and less fat, especially the visceral fat. And all of this, like insulin resistance, visceral fat, and metabolic syndrome, they're all basically the same thing. They're all coming out of more adipose tissue. And that is causing all the problems. So people with high BMI can maintain good metabolic health, but you do have, so there was a study in the US which was done among football players, and football players are, they will be practicing, they will have all their exercise and everything. But even in that, it was shown that there was metabolic syndrome even in them. So the people who had higher body fat had metabolic syndrome, even though they were athletes who were regularly exercising. And it was shown that once they improved this cardiorespiratory fitness, once they improved their VO2 max, the insulin resistance kind of came down. So yes, I mean, it is important. Strength training and cardio both is important, and body composition is important. It's not just about the BMI, it's a little more nuanced.
Is there any easy way to determine the VO2 max?
I don't think so. You have all these watches and everything, which I'm not too sure whether they're very reliable. So I would definitely go to the lab and get it done. But VO2 max is an important marker for insulin sensitivity also.
I don't know if, does Ramachandra do it, Shiny?
Yes.
Yeah,
I was about to, Ramachandra Medical College, the Center for Sports Medicine, Dr. Armugam sir, his department does.
They do the VO2 max.
Yeah. They have a lab.
There is a kind of a calculation where I think you run for 20 minutes and then you take your maximal heart rate and you calculate, but I'm not too sure how accurate that is.
So what happens to people who are on like beta blockers, and that's where
there is
we
an
always
equation for that also.
There is an equation for that.
Okay. Calculate your heart rate if you're on a beta blocker. But you do need to know your basal, you need to know your resting heart rate before you went on the beta blocker. So I'm not too sure how much that we will have.
Karpagam, this is for you. I think the previous sort of panelists have addressed to some extent. They talked about body composition analysis. Nritya spoke about the VO2 max. What other diagnostic tools do you think are being used, or have you used actually personally to assess your fitness level, or I don't know, your anything beyond what is being discussed? Or
she's a daredevil. Her standards are different.
No.
Really?
I just did my devil circuit this weekend.
She's a daredevil. Her standards are different. Don't ask her.
Basically, my concept is very simple.
Okay.
Actually, you're the best judge of your fitness. So I go by what I feel is right for me. My mind and my body decides what I can do and what I cannot do. So basically, there's no comparison. And from my point of view, whether it's like diabetes, metabolic syndrome, whatever it is, nobody seems to be spared. So everybody, all of us seem to be at risk. The first thing I always want to say is we have BMI, waist-to ratio, body fat assessment. All these things are there. VO2 max, all the Garmin, Strava, every app that you have for Coros. So many watches are there, so many apps are there. Everything that actually tells us your VO2 max. And my Garmin says my VO2 max is 20-year-old. I completely disagree with that, actually. Because it is something which is determined by the amount of training or the amount of work that you do. It's a software that is fed inside, but that may or may not be true. So for me, I am the best judge of my fitness, and I always believe that whenever there is a marginal rise in body weight, marginal, even a 3 kg, 4 kg weight gain, my blouse doesn't get in. So I'm more concerned about that, and that is a point of time where I realize that I need to be more intense. For me, the only logic that works is 30 minutes of sweat-inducing exercise 3 to 4 times a week. That is more enough to keep our metabolic parameters under control. And I know all of us run a very high risk of metabolic problems, and we have to understand our own things. And there are a lot of other aspects that these actually devices, or there are a lot of things available: strength, muscular strength checking, muscular endurance checking, cardiovascular endurance, physical flexibility, body fat composition, all these machines, so many things are available. But at some point of time, I feel, they put more stress than when you see these values out of normal range, you are so stressed mentally. And that actually puts a lot of people off that, okay, you're way beyond normal.
So they get very stressed and they start doing either they start increasing their intensity more. That completely deranges their metabolism. And as Dr. Shaini was telling, I have 3 of the athletes who are into totally hypogonadism because of high intensity workout. They are actually not, they're amenorrheic. So I had to tell them that, they are completely into protein diet, no fat, no carbohydrate. They are into the typical athletic triad. I have a basketball player, I have another cricket player. So they are totally into that. So I keep telling them, so you need a certain amount of body fat to initiate menstruation and certain amount of body fat to maintain menstruation. So you're actually losing out on that, focusing on more on your muscle and your bone strength. So actually it is a balance. So, and as Dr. Nitya was also telling, more than BMI, I am more concerned about the waist hip ratio. So there are people who are actually having very thin body frame, the lean BCO, but the central obesity, the waist hip ratio really has more, it supersedes everything else in terms of, that is the easiest and the most easily, you don't even have to measure sometimes. It's very obvious when they walk into the clinic. That is very, very important. I know numbers are very important in terms of, BMI, waist hip ratio, all these things. But when the numbers, when they put stress on them and just it doesn't help. So they actually, a lot of comparative attitude is there, and physical strength and mental strength are complementary to each other. So they have to be mentally strong to accept the fact that they have to improve their physical strength. So what happens is they actually get stressed and I know people who are so depressed, they actually send them to counselors to say that everything is fine with them, just that they need to work on their basal fitness levels. Nothing else. There is no major illnesses that is life-threatening. So that is one thing which is, people have become very conscious about their looks and everything. Yes, it is important. Presentation, our looks are important, but the overall fitness is very, very, very important. And as everybody suggested, very important for strength training and high intensity training when they have to do a weight loss over a period of time. Rapid increase in weight, rapid decrease in weight, both can be very deranging. So my point is that more than these parameters assessing things, I think it's very important to be our own judge of our own fitness.
I think your standards are high, Karpagam, so you'll become more.
No, ma'am.
My standards are very
Absolutely
low.
no, ma'am. I don't run marathons like to half marathon, full marathon. I know my capability. I stick to 5 kilometers and 10 kilometers, and I don't even have time to do my strength training properly. But that is, it keeps me going because I do something or the other. Something is better than nothing, Madri, with available time.
Agree.
So this question, I'm just going to rephrase it actually, Meera, because I think everybody has spoken about all the strength training and all that. What I wanted to ask was 2 things. One is, one of the things that Karpagam was mentioning, work out till you sweat, if you're going to address the cardiovascular aspect. When you become used to that, what do? Do you change your exercise? Second,
you have to.
Either you or Nitya, I just want you to address this concept of, do we each have like this individual set point for fat above which we are going to develop problems? There is this concept now of personalized fat threshold, something like that it's called. So, for you, a fat of whatever, like 35% may be okay. For me, 35% may be too much, something like that. So, yeah, maybe the first question I was asking about, how do you push your fitness level?
The fitness level is again determined by your holistic improvement, both in life and lifestyle. Your comparison should be yourself and not others, be it numbers, be it efficiency, be it performance. It should be in relation to what you have been able to do previously. So that determines our exercise efficiency and performance. And similarly, your body gets adapted to certain type of exercises. That is why you need to keep changing the routine. That is why the mixture of cardio, weight lifts, strength training, and balance and flexibility have to be incorporated into the exercise routine. Otherwise, your body will definitely get adapted. And the result which you would otherwise love to see with this kind of exercise might not be produced because there's acclimatization of the body. So you will, if you want to ask, you can push yourself, knowing that you've reached that kind of plateau. So that depends upon how you feel about it, and that should be done to improve your cardiovascular efficiency also. And cardiorespiratory efficiency definitely can be improved. That is what is shown in cardiac rehab programs, even for patients who have undergone angioplasty, stenting, and even cardiac bypass. So if we just take sweating as an example, sweat and then you stop, most of our high BMI patients will stop in 5 minutes. But that's what is going to tell them they can push themselves. If they proceed to 15 minutes and they're still not sweating, that has definitely improved their exercise efficiency. So that is very, very important for us to understand, so that we also educate our patients depending on that. With regards to the second question, I think both of us will take it. I have a view that it is definitely personalized fat ratio, because as I said, it depends upon the gender, it depends upon the ethnicities, depends upon significantly the family history and other parameters which crop up with your pre-existing diseases like PCOS, nowadays breast cancer medication, so many other factors. We see a lot of women who are young, premature menopause, and who have obesity, central obesity, and deranged metabolic parameters. Especially, I see a lot of Northeast patients who are thin, but extremely deranged metabolic parameters, right from a young age. So these are important factors to be considered on a customized basis rather than one arbitrary range set for everybody. So it should be in the clinical context of that particular index person. That is my view. Nritya.
Yeah. As far as the first question is concerned, I don't use, I mean, I would say that people have to follow the minimal physical activity recommendations. That's something that everybody has to do. So your 30 minutes of moderate intensity activity at least 5 days a week. And I would define moderate intensity as use the talk test. That would be the easiest. For people who have a smartwatch, I do calculate the maximum heart rate and tell them percentage of MHR that they can use for patients who have smartwatches, or they wear a heart rate monitor sometimes. But otherwise, I definitely say moderate intensity. A lot of times people say, yeah, I walk around the park, I walk for an hour. So they can walk for an hour, but they might be only covering about 2 kilometers. So that doesn't really cut it. So I think it's important that we give them very clear, defined targets to achieve, so that that will help them improve their cardiorespiratory fitness. As far as individualized fat stores are concerned, I think there is a lot of genetic determination in that. All of us do store fat very specifically to ourselves and our family histories. So there is definitely a genetic determination as to how much fat I can store. It will be different for each person, and especially for women, I think we end up being at a slight physiological disadvantage, because at various points in our lives, we are physiologically going to store more fat. Like during puberty, that happens. During pregnancy, that happens. So it has to be individualized. And
I think, yeah, sorry, go ahead, Nitya.
no, and also as far as weight reduction is concerned, I like to think about weight loss as a side effect. So I don't want to stress on weight loss, because a lot of times, especially now with body image being so important, I think it's important to tell them that you do all of these things, and if you lose weight, it's great. But what we want to do is we want to get all the other things under control. If you're looking at, triglycerides level, elevated enzymes, elevated blood sugar, fasting blood sugar, stuff like that.
I think well said. Well said. Weight loss is a desirable side effect.
If you're not looking at it, I mean, I don't want you to lose weight, but I want you to, follow the fitness recommendations, follow the diet recommendations. And if you lose weight, great.
I think Spurti, I don't know, she has a question or comment.
Just a comment. I think this, especially in the current age where we see one extreme, where we see a lot of sedentary lifestyle, they go for a walk, but just like how Nritya was saying, They're not even breaking a mild sweat. And on the other hand, you have people that are so-called fit, go for a run, and then are dying. So, the question I get asked quite a lot in my clinical practice is, am I doing too much? Am I doing less? And sometimes it's very difficult to tell them, just trust in yourself and go, because that's exactly where we're seeing people fall down and dying. So there are a couple of things that I do. If my patients are not very technological, they just kind of want to know, am I doing the right thing? I teach them about perceived exertion, RPE, right? And kind of give them a scale of how you're doing and how do you, so, you teach them about, usually I say 5 to 7 perceived exertion is kind of the way to go, but really depends on where they're coming from. Say they're coming out of a post-viral illness, I might go very, or after some form of surgery or say a stent, then much lower RPE, and then how to kind of gradually go up. I think that has really helped me, especially if they have already done a treadmill test. Then it's very easy for me to tell them, okay, you went to a METS of almost 10 and you had a negative stress test. So you know how you felt at that time. So you're okay pushing yourself to about 80% of that. This is kind of what seems to help my patients at least understand how much to push themselves. The second thing, for my more tech advanced fitness, people that have all your Garmins and other stuff, is your zones, right? Heart rate zones. So usually a zone 2, zone 3 for fat burning and aerobic capacity is what I would tell most of my fit patients who have all their heart rate monitors to kind of work on. And people who want to keep increasing their fitness and endurance, maybe zone 4, little bursts of it. There's 4x4 Norwegian principles, your VO2, and that's kind of where. So I think these are two ways that at least I tell my patients. And just one last point is, when you're looking at this muscle mass percentage and what is okay, I think that was the question there. Quite a few studies that have shown sarcopenia with increased mortality, morbidity, and poor quality of life. So I think a cutoff of definitely anything more than 55% muscle mass. And then beyond that, yes, personalize how we look, etc., etc. But anything less than 55%, I think, has a high connection to mortality and morbidity. So I just wanted to add these few things from my experience.
Thank you. Thank you, Spurti. Yeah, I think you've addressed this, Shiny, but how when you're sort of counseling people, so like Nritya was saying, when you're seeing somebody and we're going to tell them, look, focus on all these things. If you lose weight, well and good. But if not, I mean, it's more about, getting the triglyceride down. So how do you sort of address this issue?
Yeah.
And particularly obviously we all know about protein.
Yeah.
I think Sheila had mentioned that we need to go up to 1.2 to 1.5 gram per kg per day. Do you agree with that?
Yes,
and
I do.
How is that achievable in the absence of taking supplements in a vegetarian South Indian diet?
Yeah, I think that's the challenge. Yes. Okay. Yeah. Dr. Sheila did mention that 1.2 to 1.8 gram per kg body weight. In fact, there are times that women respond when we step it up to 2 to 2.2 gram per kg body weight. Because we have a lot of 40-year-olds coming in and they have all the symptoms of perimenopause and they're struggling with a lot of gastric issues. So they're not able to take a lot of lentils, legumes. The sundal is out of question. They said, I'm already struggling with a lot of gas and my waist is looking bigger and I'm not comfortable going out. My blouses don't fit. And by evening, the inskirt is so tight. There's so much of bloating and I don't know what to do and how to deal with it. And there are times that they have plantar fasciitis or there could even be a lot of tightness. So every single day, I think use of magnesium. I've been using a lot of magnesium supplements and that's been pretty helpful along with pyridoxine and also omega-3 fatty acids because, if you are a vegetarian, you're not really getting adequate amounts of omega-3 and the ratio of omega-6 and 3 is always an issue when it comes to dealing with our population. And another factor is also low carbohydrate works really well because there's underlying insulin resistance, as all of you have mentioned. Yes, they have skin tags, they come with acanthosis and a lot of hair thinning in spite of eating right, and still they do experience hair thinning. So that really hits their self-esteem in a very big way when women are losing hair. And there's also a lot of hirsutism and pigmentation. There's melasma. So all of this really hits them so badly. And I think the sense of self-worth and self-love and the body image issues, we have to deal with all of this. So we always closely work with a therapist. It helps a lot to handhold them through that phase because they're also going through insomnia and all of that. So low carbohydrate helps a lot. The idea is to bring in a lot of nutrient dense foods. So even if they're not eating rice and all of that, a low carbohydrate diet wherein either say rice rolls, or else like say shirataki noodles, if they can afford to make all of that, or else just having some tair pachadi, or else raita and a kootu curry, that kind of works really well in a South Indian setup. Or else there are times that we do give this adai, or else a pesaret, or else like a besan chilla, that's the chana dal flour ka dosa, and coconut. So we really have to make sure that there are comfort foods. So the ethnic background is very important, and say a little bit of rice, or else a little bit of quinoa with more korma and parpusli, that also works really well. A chutney or tovial adds a lot of flavor, and the burst of flavor kind of keeps them going. And sometimes a roasted papad, so just the crunch rather than a fried aplam or badams, this kind of helps a lot, or else a air fried ones, and sometimes sticky. So there are times that we want comfort foods like say a chaat, and then we just say tawa fried cutlets, or else a air fried cutlet, and that with homemade curd, and you're more in control of how much of sugar is added to the tamarind chutney, or all the ingredients can be really fine tuned. Next thing is also nutrient diversity and gut health, because the gut brain connection is very strong. And we also see, even if one is not in perimenopause, there are a lot of people who have gluten lactose intolerance, which just goes unnoticed. So food intolerance is another important factor that we look at. And especially during perimenopause, there are a lot of allergy reactions. So hives and a lot of rashes and all of those things come. I'm sure, meaning I hit menopause during pandemic. I was 44 then. I'm 48 now. And there are days that I've gone for a walk, and then within 5 minutes, I came running back home because my vagina was burning so badly. And I just had to splash some water and just calm myself down. And there were sleepless nights, and of course, forgetting a lot of things, forgetting team meetings, calling, there were appointments that were fixed. And then I had this brain fog, and I completely forgot to call the client and apologize heavily later. So this was also the time that I realized, like, you need to step back and then also have a big team to handle it. And I hired a lot of 20, 30-year-olds at that time while I was going through this entire thing. And the emotional upheavals are also pretty bad. So, and two fractures, trust me, it was not easy. Plantar fasciitis,
Okay.
a lot of challenges. Hydrotherapy is what I'm focusing a lot on. So, and then kettlebell, for weight training, kettlebell training. So basically food diversity, nutrient diversity, prioritizing protein, getting fiber in, getting good fats, and balancing it all, and ensuring that it's budget friendly, it's sustainable. So we can't be talking about avocados and blueberries and cranberries and kiwi and all of that. Anything local helps. So this is how I would rather approach the weight loss. And to say there are days that everything is just going to stay stagnant, hang on there. And sometimes what also helps is a plant protein supplement, because they might just come back and say shundal is not working, or else this purple is not working for me. And then we keep looking at a whole lot of other options, and then include unflavored protein, which can just be mixed with curd, or else maybe even with buttermilk, so that the gut health and this is taken care of.
Absolutely.
These are just some of the tips that I would like to share.
Thank you. Karpagam, what about you?
Yes.
Any other tips
I'm
in
a
the
very
diet?
traditional person, very desi
Yes.
person. I don't have any supplements. I don't take any supplements. And I believe in eating healthy. I believe you are what you eat. So I eat everything vegetarian under the sun, everything vegetarian. The maybe I quantity is maybe more. And I always believe that, as she said, there is a lot of origin vaitikaga we are eating, and that controls the entire body. I believe in that. So I strongly believe in that gut health, where in those days people ate healthy and they were thinking healthy. So there's a lot of connection between the way you think and do things about. So I give a lot of respect to food and a lot of respect to eating. And I'm very traditional, no supplements. And maybe, I mean, as Shani was telling, I hit menopause at the age of 42. Now I'm 46. So the only supplement that I'm thinking of taking is calcium, because definitely we are all housebound. And even though I do bit of an exercise, how much ever possible over a week, I mean, it's just as she said, it's poor man's protein that I eat, like, not like cranberries and all those things. Pottikadale, groundnuts, all those protein, and vegetables in plenty. I would say like plenty. And actually 2 days back when I went to Apollo to donate blood for one of my friend's patients, the doctor was very surprised. The first time I'm seeing the lady patient with a hemoglobin of 14.3. I said, I have always maintained that ever, because that's only because of I owe to the kind of diet I'm eating, nothing else. Thank you.
I think Nitya has something to say.
Yeah. So I actually just wanted to say that I think Shiny had put in a reel today or maybe yesterday about all the refined carbohydrates. So I think that's where
breakfast, five
yeah,
breakfast.
yeah. So
Yeah.
I think carbohydrates, the whole grains or the complex carbs are fine, but like she had put in, most of our population is having rava, semia, puri. So that's where the problem lies. So we need to kind of change that diet and ask them to include, like she said, the basin chilla, peserettes, things like that. And as far as so it's good to follow the exercise prescription of doing the physical activity 30 minutes minimum and doing strength training, but it's also important to be active through the day. So like we've been sitting now for almost 2 hours. So yeah, that's not a great thing to do. So all of us should get up and have like most of my patients, I tell them get up every 30, 45 minutes, just take a walk around the room or just do a couple of standing marches. It's important to keep physical activity, not necessarily exercise related, but just make sure that you're moving about. So that's also important. And like Dr. Karpangabal said, it's very important to be perseverant and consistent. Finally it will pay off. You will have days where you are, just the same weight. It's not happening. It's not moving. But the thing is that we should just continue to do what we are doing. After all, we don't put on weight in a day, so we can't expect to lose it all in just a couple of months or weeks. So that has to be fine. I think we also need to make sure our patients understand it.
Yes.
I think there was one question in the chat box about muscle pain, how to manage, and I think Shiny had addressed it. She was talking about magnesium supplements and hydration, I presume.
Yeah. And also
is there a particular form of magnesium you prefer? Because I know the glycinate form is better for like sleep and
Yeah. I've been using magnesium oxide from nutraceutical company in Chennai, Healers Nutraceuticals. That's been pretty effective. And the combination of pyridoxine and magnesium also helps. But there are some who choose to use magnesium glycinate. I don't stop them from doing that. This is much more easier to source, for Chennai clients. Yeah. And magnesium also comes in sprays and also as an oil, so they can just rub it. So even for menstrual cramps and all of that, they can just apply it on the abdomen and they can use it. And we also use a lot of magnesium spray and oils for athletes as well, for cramps in the leg and all of that. It works beautifully and calms them down. Insomnia is taken care of, and any of those muscle related twitches and all of that. Yes, omega-3 as well.
I think in the interest of time, I think we should close up. There is another question. I'm sorry. Maybe you can send it to me and I'll send it to the question is Shiny, how to avoid addiction issues with artificial sweeteners and salt supplements. So,
okay.
I mean, it may,
Yeah,
can you give us a brief, like 20-second answer?
Yeah, just limit the sweetness to just the tea or coffee. That's it. Do not prepare any sweets with it, because when you're, say for instance, you're making a Mysore pak with artificial sweetener, look at the ingredients and see the interplay of the fat and the basin and the ghee and the sugar and all of that, plus the artificial sweetener. And I think that is where the issue with, or rather the connection to carcinogen and, all of that comes in. So it's better to just limit it to tea and coffee. And that too, I hope your tea and coffee is just 2 cups a day, which is just 400 ml and not more, because I'm dealing with clients who take like 10 to 12 cups of tea or coffee per day. So 2 cups, just that. That's
And
it.
tell them if they have to eat a Mysore pak or a laddu full, just think about what they would have to do to expend that. Quit to a half marathon. I don't.
Wow, they can't do it all of a sudden, yeah.
Unfortunately, that's not enough of a deterrent, Meera, for some of us.
Yeah.
That's nice. So you would take part of it.
Yeah.
Yeah. And one thing is,
yeah.
sorry, ma'am, one last thing, just when Spooty was talking about this runners having this sudden deaths, the most important thing that we always do is, because I belong to a running group where we hear the cycling group where we hear this news very often, and it's so tragic. Even the Tata Mumbai Marathon that was conducted recently, fortunately, we know FCM Chennai Marathon had absolutely no casualties, but Mumbai Marathon had casualties.
Yes.
And then the problem here is basically they do intense training over a period of maybe 6 months, and it should be done very good. I'm a part of this group for the past 5 years, but still have not decided to do half marathon or full marathon because I'm not able to put that much amount of training on a regular basis. So what they just sign up for that, and then a span of 3 to 6 months they do intense training. Actually, there is something called as runner's heart, where the cardiac hypertrophy happens, and the most important thing is arrhythmias. So the most important cause of death for runners is arrhythmias. So please, I think the problem here is not running. It's not this thing. So people actually get scared when they hear such news in the group, and everybody panics. Especially when these young 40-year-old people, 40, 45, actually they are quite young. Very rarely people above 70 get into this sudden death during running or anything. It's most of them are between the 40 to 50 age group. It's very tragic to read those news, and it's very so most important thing is they develop actually even in the recent Perinalmana marathon, we had a very young doctor, who had a cardiac arrest, and it's mainly because of it seemed to have the people should actually have a baseline checkup of their cardiac condition, and then do things very graded. And if they can do a moderate exercise and keep themselves fit, that's more than enough. Sometimes, I don't know, sometimes they push with their mind more than their body. So that is very detrimental, and it's very, very tragic for the entire running community as well as for the family, more for the family actually.
In a lighter vein, when you are doing this 10K or whatever, and you see this new group of recruits from the IT who do the run for the heck of it, you can see them commenting, "Na enga amma ko re payenda tirbi pono nadande pola parvala."
That is different. See, they are actually coming in groups. They have bulk bookings, corporate bookings. No, so corporate bookings for charity. No, what they do is they're actually coming there to have a chat, and they take nice selfies of the group and put it on social media the next day.
Artists, they will be so glued up to the breakfast which is being served.
Absolutely. Come on. See, breakfast is more important for them. Yeah. It's actually a nice thing to do it. So you please understand your own metabolism and go ahead. Just don't compare yourself. Don't do it just because somebody else is doing. Somebody who started running with you is doing. Don't get carried away with what is happening around. You are the best judge of yourself.
Absolutely.
Thank you very much to all of the panelists, Dr. Karpagam, Dr. Meera, Shiny, Dr. Nritya, and also to Spurti and Sheila, who did stay around. Sorry, Sheila, I didn't see you on my list. Otherwise, I would have picked your brain. Thank you very much. I think one of the messages I wanted to put across is please look beyond the weight. Though we keep talking about weight, and waist circumference, and please start looking at people's metabolic health. And I think, as Nritya said, if you manage to lose weight with your proper lifestyle changes, that's a good thing. If not, it's okay. At least keep looking at your metabolic health, because ultimately that is what is important, irrespective of your body weight. With that, I'll finish up and turn it over back to Kartika.
So we have come to the end of this very interesting, informative academic session. So before we conclude, Sahiti, can you just share the results for the quiz?
Yes, ma'am.
So there were totally 30 participants for the quiz. So Gomati Madhyalagan has come first. She is the fastest among the scorers, followed by Kartika M and Shanti AR. Congratulations to all the winners. Shall we conclude?
Yeah.
Yes, please. Yeah.
So thank you for all the faculties and delegates for our active participation in this webinar to make it a very grand success. Thank you, Shanti ma'am and Meera ma'am, for giving us an opportunity to coordinate the session. Thank you, Jayashree ma'am and Anjalakshmi ma'am.
Thank you. Thanks,
Ma'am,
Kartika.
you want to add something, ma'am?
Nothing. I just wanted to say a big thank you to Kartika and also to the Sahiti Shield team for a smooth, hitchless sort of conduct of the proceedings. And thank you to also all the chairpersons who joined us. Thank you, Dr. Geeta. I think she had left. Yeah. Thank you very much. Yeah.
Thank you, ma'am.